Hi, I'm Jane Goodall. This is Charles, who's consented to an examination of his foot and ankle today. He's no underlying pathology and is fit and well. So after a complete case history, the physical examination starts with an assessment of Charles's movement patterns and his core stability. So Charles, if you can walk slowly up and down the room, and we're assessing for symmetry and smoothness in his gait, if there are signs of antalgia, any foot drop that could indicate a weakness in his tibialis anterior, or a common peroneal nerve palsy or sciatic nerve palsy. For instance, Charles, if you can walk now on your tiptoes and then turn around and walk back on your heels. So we're assessing now neuromotor function, and Charles seems to have fairly good integrity of his nerves and muscles. That's fine. And then if you do a squat down for me, that's great. And we're again trying to now exacerbate any signs of any impingement in the ankles. That's great. And then if you can stand on one leg, Charles, and squat down 90 degrees. We're looking for any internal rotation at the knee, any hip drop, or any swaying in the torso that could indicate any core stability and balance issues there. We'd also do that on the other leg and then repeat that on an unstable surface as well, such as a cushion or a mini trampoline. Super. So the next part is to inspect Charles from the front and the sides and the back. And we're looking for signs of scars which may indicate previous surgery or injury, trauma to the area, any swelling, again down the ankles. If we're looking at unilateral, it's more indicative of a trauma or an injury. If there's bilateral swelling, we may be thinking that there's more cardiovascular or lymphatic problems, perhaps a pelvic obstruction to venous return. Any erythema, and we're looking and comparing again both sides, muscle bulk, if there's hypertrophy, atrophy, or fasciculation. And then we're looking at general alignment, so if there's any pelvic tilting, any femoral anteversion, valgus or varus at the knees. Valgus in particular is frequently responsible for overpronation at the foot, and then we're looking down towards the feet to see if there are any abnormalities there, such as hallux rigidus or any bunions or any claw toes or hammer toes, and around at the Achilles to see the alignment there, and the hind foot as well, posture. Okay, that's great. So that seems to be fine. So just lie on to your back, please, Charles. And the next part of the examination, I'm going to do a brief neurovascular assessment. Just relax there. So I'll start off assessing for temperature. It's fine. And then capillary refill in the elbows. Lovely. And then I'm going to check his pulses, so dorsal pedal pulses and the posterior tibial pulses. Great, and check for sensation. So just tell me if this feels equal. Close your eyes, Charles. So it's the same each side.
Yeah.
L4,
Yeah.
L5,
Yeah.
S1. And I'm going to check my tomally distally here. So push your feet up towards you. That's great. L4. And then the big toes up. L5. And then push down into my hands. S1. That's great. You can also continue just observing as well, see if there's any problems on the soles of the feet as well, any callus formation, any swellings, and on the dorsal aspect as well. That's great. Okay, so then I want to go on with palpation. So we can start by palpating around the lateral aspect, so lateral malleolus. Is there any tenderness there, Charles?
No.
And then we can palpate the lateral collateral ligaments here, so just distal to that we've got the calcaneofibular ligament, and behind that the posterior talofibular ligament. Just tell me if there's any tenderness.
No.
And then anterior to the lateral malleolus, we've got the sinus tarsi, in which there's the anterior talofibular ligament, which is often injured in inversion sprains. Okay, so we can come off there and palpate around the cuboid. It's lovely. Okay, and we can palpate the peroneal tendon down to where the peroneal tubercle is on the calcaneum. This is where the peroneus longus and brevis will sort of split round, and it's a site of tenosynovitis, and then follow it round to its insertion on the base of the fifth, the styloid process of the fifth metatarsal there. And again, we can palpate individually the metatarsals and give them a little squeeze. Any discomfort?
No.
That's great. Between the third and fourth is often a site of pain, known as Morton's neuroma, elicited. Any discomfort there?
No.
Okay. And medially, we can palpate the medial malleolus, which is quite difficult to see there. Certainly. No discomfort there?
No.
And into the deltoid ligament, which is injured in eversion sprain. Okay. It's lovely. Just posterior to that is the posterior tibialis muscle and the posterior tibial artery. Okay, and then we can palpate into the navicular and the first cuneiform. That's lovely. And then onto the base of the first metatarsal, where the tibialis anterior inserts. That's great, along the medial arch there in the metatarsal. We can then move up into palpating in the flexor hallucis brevis tendon. If we just push that toe into dorsiflexion and feel for the sesamoids, they're sometimes quite irritated. They've got quite an important job to do in dissipating weight-bearing forces, since that first metatarsophalangeal joint's responsible for toe off, and you need a fair amount of movement there as well. That's good. Lovely. Okay. I'd also palpate the Achilles tendon, so just bend your knees slightly, Charles, and tell me if there's any tenderness there.
No.
Up into the gastrocsoleus muscle, no problem. Peronei, no problem there.
No.
Great, fantastic. Lovely. So then I'd go on to test for active range of movement. So Charles, if you can bring your toes up towards you. So that's dorsiflexion, we'd be looking for about 20 degrees, and then point your toes down as far as you can go. Plantarflexion, looking about 50 degrees, and then bring them inwards. That's lovely, about 5 degrees, and outwards into eversion, another 5 degrees. Then I'd want to passively move the joint. So if you just allow me to move your ankle, Charles, your foot and ankle. So into dorsiflexion. I'm feeling passively here for crepitus, the quality and the range of movement, and the end feel. That's dorsiflexion, plantarflexion, and that's at the talocrural joint, and then we go into inversion at subtalar and eversion, which again should be limited by the lateral malleolus there. It's lovely. And then we'd look at forefoot adduction and forefoot abduction. Lovely. And I'd want to also test the big toe, first metatarsophalangeal joint in particular, so it's quite an important joint to test. So we're looking for 70 to 90 degrees here of dorsiflexion, and about 40 degrees of plantarflexion there. No problems there?
No.
Lovely. Okay. Super. So then I'd want to go into active resisted or resisted isometric testing. So Charles, if you can then push up your feet towards you against my resistance, that's great. And then down into my hands, lovely. And then push outwards, great. And then push inwards, lovely. And the big toes push upwards and downwards. Fantastic. Okay. So the next part of the examination, I'd want to perform some special orthopaedic tests. And the first tests actually put stress on the ligaments. So to test for the anterior talofibular ligament, what I do is test for an anterior draw sign. So I stabilise the tibia and then I draw the calcaneum anteriorly. And I'll be looking for 5 or more degrees of movement there, which would start to be a little excessive and could indicate ligamentous laxity or a sprain injury. We could then do the talar tilt test, so we can invert if there's tenderness and excess movement of these lateral collateral ligaments. It's indicative of a bit of ligamentous laxity or sprain injury. And the eversion talar tilt to test for the deltoid ligament. Okay, no problems there?
No.
Great. If you lie on to your tummy for me. So the next test, if you just bend your knees, is to look for a ruptured Achilles. It's a Simmons test, and we can start just by observing if the foot or one foot was in dorsiflexion, that's a sign. We can then go to squeeze in the calf muscles, and it should dorsiflex. If there's a rupture, there'd be very little to no movement whatsoever. Okay, any tenderness there?
No.
We could also do the Royal London Hospital test, which is quite sensitive and specific for diagnosing a tendinopathy here. So we palpate if there's tenderness around the tendon. So palpate, again, sometimes it can be at its calcaneal insertion or in the mid portion of the tendon there. If there's tenderness there, according to the test, if on dorsiflexion there's more pain, that would be indicative of a tendinopathy. And also you'd be looking for a positive arc sign where you'd see the swelling would actually be moving along the tendon with the movement too as well. So that completes our examination of the ankle. To conclude, I would want to do a full assessment of the lumbar spine, his hips and knees. Could refer, if there's pathology there, could refer to the ankle and foot, and also perform a full neurological examination if indicated and request further imaging. Thank you.